Insomnia disorder, a dissatisfying quantity or quality of sleep that leads to some form of daytime dysfunction. Epidemiology. Insomnia is the most common sleep-wake disorder, affecting 10% of the population worldwide. Prevalence is higher in women, shift workers, and people with physical or mental disorders or disabilities. Etiology of insomnia disorder. Predisposing factors include a chronic state of cognitive and physiological hyperarousal, and medical comorbidities, including mood and anxiety disorders, can lead to insomnia. Causative factors are bidirectional, and that is, psychiatric conditions may lead to insomnia, or insomnia may lead to psychiatric conditions. Precipitating factors, for example, stressful events, acute or chronic. Perpetuating factors, for example, poor sleep hygiene. Clinical features include difficult falling asleep, maintaining sleep or early morning awakening, non-refreshing sleep, impaired daytime functioning. Potential health consequences: development of mood disorders, for example, major depressive disorder or bipolar disorder, and increased risk of suicide. Workplace injuries, reduced quality of life. Clinical assessment of insomnia disorder: inquire about sleeping habits and bedtime routine, determine symptom onset, triggers, and interventions already tried, for example, non-pharmacological measures and insomnia medications, identify nighttime symptoms and assess their frequency and pattern, difficulty falling asleep, staying asleep, and/or waking early. Ask specifically about bedtime, time until falling asleep, number and duration of nighttime awakenings, and morning awakening time. Behaviors during sleep, including snoring, leg kicking, snoring, obstructive sleep apnea, leg kicking, periodic limb movement disorder, alternative diagnosis to insomnia disorder. Ask about daytime impaired functioning and/or sleepiness. Medical and psychiatric history should include comorbid conditions and associated symptoms that could interfere with sleep, for example, pain, itching, shortness of breath, gastrointestinal symptoms, and nocturia. Medication use, prescription and over-the-counter, and the time at which medications are taken. For example, some patients who take antidepressants in the evening experience difficulty sleeping. Diuretics should be taken during morning hours. Avoid nocturia. Alcohol consumption, use of stimulants, for example, nicotine, caffeine, and sedatives, for example, opioids, benzodiazepines. Withdrawal from sedatives can cause insomnia. Occupation, school, and working hours. Identify shift work and occupations that involve driving or operating heavy machinery. Medications that may interfere with sleep include decongestants, for example, pseudoephedrine or phenylephrine, bronchodilators, for example, albuterol or the theophylline, antidepressants, antihypertensives, for example, beta blockers, calcium channel blockers, diuretics, glucocorticoids, sedatives, and hypnotics. Non-pharmacological management of insomnia. Sleep hygiene. Avoid factors that may trigger or exacerbate insomnia. Use the bed or bedroom only for sleep or sex. Avoid alcohol, caffeine, and nicotine close to bedtime. Exercise regularly, but not within 3 to 4 hours before bedtime. Avoid daytime naps. Avoid large meals and fluid intake in the evenings. Avoid bright lights, including electronic screen use, before bedtime. Stimulus control. Re-establish the association between bed or bedroom and sleep. Discourage engaging in other activities in bed. For example, avoid working, reading, eating, and watching TV in bed. Wait to go to bed until feeling sleepy. Establish a consistent sleep or wake schedule. Maintain a regular sleep or wake cycle, waking up at the same time every day. Avoid naps. Relaxation training. Reduce physical and cognitive arousal and anxiety. Progressive muscle relaxation, for example, yoga. Visual imagery. The patient is instructed to mentally focus on pleasant and relaxing images. Pharmacotherapy, sleep onset insomnia drugs are used when there is difficulty initiating sleep. Melatonin, Ramelteon, Z drugs, eszopiclone, zaleplone, zolpidem, benzodiazepines, preferably short-acting benzodiazepines like triazolam, cevorexant, orexin antagonist. Sleep maintenance insomnia drugs are used when there is difficulty maintaining sleep. Z drugs, eszopiclone, zolpidem, doxepin, cevorexant. Early morning awakening insomnia drugs are used when a person awakes early in the morning and then feels difficulty to sleep again. Doxepin, cevorexant. Insomnia drugs in older adults that are greater than 65 years old. Doxepin, melatonin, Primergion. Insomnia drugs with comorbid depression. Doxepin, mirtazapine, trazodone. Insomnia drugs in pregnancy. Doxylamine, diphenhydramine. Doses of sleep medication: Zaleplon 10 to 20 mg per oral once daily at bedtime. It should be taken 3 to 4 hours before planned awakening time. Zolpidem 5 to 10 mg per oral once daily at bedtime. It should be taken 7 to 8 hours before planned awakening time. Aszopiclone 1 to 3 mg per oral once daily at bedtime. It should be taken 7 to 8 hours before planned awakening time. Zaleplon, zolpidem, eszopiclone are benzodiazepine receptor agonists. Triazolam and temazepam are benzodiazepines. Triazolam 0.25 to 0.5 mg per oral once daily at bedtime. Triazolam is short-acting. Temazepam 7.5 to 30 mg per oral once daily, 30 minutes before bedtime. Temazepam is intermediate-acting. Melatonin, it has good efficacy and safety profile. The dose of melatonin is 1 to 3 mg per oral once daily, 30 minutes before bedtime. Ramelteon, the dose of Ramelteon is 8 mg per oral once daily within 30 minutes of bedtime. Melatonin and Ramelteon are melatonin agonists. Cevorexant 10 to 20 mg per oral once daily within 30 minutes of bedtime. Cevorexant is an orexin receptor agonist. Doxepin is an tricyclic antidepressant. The dose of doxepin is 3 to 6 mg per oral once daily within 30 minutes of bedtime. Thank you.